everyone. Welcome to join the first episode of Mindray HemaTalk Webinar today. I'm Jeff Fu, a hematology product marketing specialist of Mindray IVD. It's a great honor for me to be the host today. HemaTalk is a scientific program to connect laboratory professionals, doctors, hematologists, and pathologists around the world to share their knowledge on hematology. We've been committed to this scientific program since the beginning of last year. As we know, COVID-19 is currently having a huge impact globally. Until today, around 200,000 people are confirmed with the disease, and nearly 8,000 people's lives have been claimed in the world. Mindray, as a leading medical device manufacturer in China, also shouldered great social responsibilities of supplying much-needed medical equipment to Wuhan, Hubei province during the fight against the coronavirus at early stage. We wish to spread our knowledge on COVID-19 to more international fellows and hope we could fight and win together. Today, we are honored to invite two distinguished speakers, Dr. Henry Huang and Dr. Raymond Simon Lopez, to give a lecture. This is the layout of the webinar's agenda. Firstly, I would like to invite Dr. Henry Huang to give a topic on hematology's indispensable role in COVID-19 diagnosis and prognosis. Dr. Henry is a Senior Director of Mindray Medical and Scientific Division. He is also an adjunct professor of oncology in the Department of Surgical Oncology and Roswell Park Comprehensive Cancer Center in Buffalo, New York. He has conducted more than 15 major research projects funded by USA and Chinese governments, and also published over 100 peer-reviewed scientific papers. Now, I'm going to leave the screen to Dr. Henry. Hi, Dr. Henry. Can you hear me?
Yes. Hi, everybody. Good afternoon here in Shenzhen, China. Is everybody hearing me well?
Yeah, we can hear you. No problem.
Okay, so let's begin. Now, since everybody is talking about the pandemic of coronavirus and the disease it caused, the COVID-19, so as of today, the March 18th, over 180,000 persons have been confirmed for the infection. So I think it's kind of pandemic crisis right now. So it has been happening in almost every country in the world. So it's kind of a public health emergency. So at Mindray, we are working alongside with the healthcare personnel globally and to fight against the virus and the disease COVID-19. So we are medical devices manufacturer and provider. So in IVD division, so we are talking about the laboratory diagnosis and it's assisting in diagnosis and prognostication of the disease. So the topic today is focused on the hematologist analysis and its clinical significance in the COVID-19 diagnosis and prognostication. My talk will cover the following areas. First is the coronavirus and the COVID-19. We are going to get some knowledge about prognostication. I'm sorry, a little bit, some minor problem here. Okay, let's continue. So let's see the structure of coronaviruses. Look at this picture, the image which I downloaded from online. This is the picture, the structure of a virus. So you can see many yellow spikes here. We call it spike glycoproteins. And here there are some shorter in blue color here. They are the hemagglutinin esterase dimer. So you can see it's two little pieces here. So it is called a dimer. So and then you see here there's one red ring here. This is the wall of the virus. We call it the envelope. Okay, and inside the wall, the envelope, you can see the pink single-stranded. This is the RNA and the N protein of the virus. So the coronaviruses are a large family of viruses. This family of viruses cause illness ranging from the common cold to more severe disease such as severe acute respiratory syndrome, the SARS, and the Middle East respiratory syndrome, the MERS, novel coronavirus, which in short is nCoV, is a new strain that has not been previously identified in humans. They are transmitted between animals and people as far as we know so far. Let's see the transmission, or let's say spreading of coronaviruses. Let's look at the SARS first. The SARS is severe acute respiratory syndrome coronavirus. It was first reported in Asia, especially in China, in southern China, in February 2003. The illness spread to more than 2,000 countries in the world. That the outbreak of SARS led to a total of 8,098 people worldwide became sick, and of this, 774 died from this infection. The SARS spreads by close person-to-person contact, and the virus is thought to be transmitted, spreading most readily by respiratory droplets produced by the sick person when they cough or sneeze. Okay, and there is speculation of transmission of the SARS. Look at this image, the picture. We see there are two animals here. One is bat, the other one is masked civet. When you look at the masked civet, actually it's an adorable animal. So people eat their meat, and that it is believed that these animals may be the intermediate host of the virus. So when people eat their meat, so people get the virus from these animals and then get infection and then spreading among people, among humans. Okay. The second one of the coronavirus is the MERS, Middle East Respiratory Syndrome coronavirus. This was happened in September 2012 because the pandemic was in that limited area in Arabian Peninsula only. So the most infected people either lived in that area, Arabian Peninsula, or recently traveled to that area. So and then they became ill, and The spreading way of MERS-CoV, the virus is likely from an infected person's respiratory secretion, such as through coughing and maybe sneezing too, So just similar to the SARS. Okay, and so that's why there is an speculation here of spreading transmission. Again, they mentioned about the camel, the bat, and then the virus get into the people in human, and then spreading among humans. The third one is the novel coronavirus, which is going on right now globally. So we call it novel because it's new and it hasn't been identified in human yet. So this is a new one. So the novel coronavirus is called the SARS-CoV type 2. So SARS-CoV-2. Cases of acute respiratory syndrome caused by this virus were reported in Wuhan, in China, first at the end of December of 2019, which is last year. So the Chinese authorities have identified SARS-CoV-2 as the main causative agent. And then the WHO has named the illness caused by this SARS-CoV-2 as COVID-19. The outbreak has rapidly evolved in affecting other parts of China, especially Hubei and then other provinces, and then right now to other countries. So also, again, same thing. The virus is thought to be to spread mainly from person to person contact. For example, shaking the hand, or when you touch the button of the elevator, etc. So between people who are in close contact with one another who is already sick. And then there is a rule here for the distance of the spreading between people. People say here in China is about 1.5 meters apart distance between people. So another way is through a respiratory droplet produced by an infected person when coughing, sneezing again. So in China, people are encouraged or demand or asked to wear a mask at all times. The origin of virus is unknown so far, but there are some speculations regarding consuming of game meat, such as the virus intermediate host pangolin here, lower picture, a pangolin, or a bat again here, and then transmitted to human. So the game meat is dangerous. So by now, China has banned it, the trading, the eating of the game meat, especially this kind of animals. So the naming, we say it in scientific terms as taxonomy or nomenclature of the virus is like this. There's specific organization which is called International Committee on Taxonomy of Viruses, ICTV, and then there is a subgroup under this organization which is called the Coronavirus Study Group, CSG. They are taking charge of this virus naming. So let's see here the naming system and or the rule is like this. For example, we see the 2003 the SARS-CoV first. The ICTV name it as SARS-CoV, and then the WHO named the disease caused by this virus as severe acute respiratory syndrome. And then second one again here, to look at the one in 2012, the MERS-CoV. Same thing, the ICTV named it as MERS-CoV, and then the WHO named the disease as Middle East respiratory syndrome. And the one right now, going on right now, the ICTV named the virus as SARS-CoV-2, and then the WHO named it as COVID-19 as the disease name. And this is the, I believe, is the first report which was published in the New England Journal of Medicine, reporting the first coronavirus scientific paper in the pandemic of 2019. Now let's see the signs of coronavirus infection. There are common signs of the infection, which include fever, cough, shortness of breath, and difficulty in breathing. In severe cases, infection causes pneumonia, severe acute respiratory syndrome, and kidney failure, and leading to death in the end. So it's dangerous of this virus. A standard recommendation to prevent infection spread include regular hand washing. This procedure especially is emphasized in the United States. They said the CDC of the US said it's even more important than wearing a mask. But in China, we are required to wear the mask and washing the hands frequently. So, and for the wearing mask, we have to wear it at all times. And you have to cover your mouth, your nose when coughing, and also sneezing to prevent the droplet, secretion from spreading to other people surrounding you. Okay, and avoid close contact with anyone showing symptoms of respiratory illness. Okay, when you see people coughing, especially dry cough, and then you feel uncomfortable, you just stay away and don't go close to him, to her. Okay. There is no specific and effective drugs to kill the virus so far, although there are some clinical trials which are going on right now in clinical settings. But we don't know for sure yet if they are effective to kill this coronavirus, although some reports mentioning that the results were optimistic, but the final results we are still waiting. Okay? We hope it's good, it's effective to kill this virus. The novel coronavirus outbreak in Wuhan, China in December of 2019, we do a little bit overview or review here. The coronavirus disease 2019 outbreak in December in the city of Wuhan, China. So right now we are facing the threat of novel coronavirus. The SARS-CoV-2 is threatening the whole world right now. As of March 18 today, there are 81,181 cases confirmed, with 3,242 cases of deaths reported in China. Okay, China alone. And there are still 2,622 still under critical condition in China. So you look at the picture here. This is I copied it from website. Some the information is in Chinese, and here is the information of the provinces and cities involved in this pandemic, in this disease. There are 337 cities involved in China. Now this picture shows you global pandemic spreading of this virus and the disease. See here, as of March 18, which is today, there are a total of 195,993 confirmed cases, and with 7,904 deaths, almost 8,000 so far worldwide. So the explosive growth has brought new challenges to the healthcare system globally. So we must hurry up to fight against this coronavirus, COVID-19. Since the pandemic, the spreading, the outbreak of this coronavirus began in Wuhan in China first. So Chinese people, the whole country actually, have been working on the fighting against this virus and this disease fiercely for almost 3 months. Beginning the end of last year. So Chinese people, including a lot of healthcare personnel and also government agency, a lot of people got involved in this fighting. So we have a lot of experience in dealing with this crisis. So the Chinese government issued a release, established several versions. So far, the 7th version already come out. The guideline on the diagnosis and the treatment of the COVID-19, and also these guidelines is in line with the US CDC. Okay, so basically very similar. So and also Chinese government authorities has classified this disease as class B, but managed as class A infectious disease. So in terms of the guidelines of Chinese authority, Chinese government, there are many aspects, contents in this guideline, very long. So I have summarized some of the key factors here I would like to share with you. First one is the epidemiology. The cause of COVID-19 is the infection of novel coronavirus 19. Okay, and then we need to be aware about the asymptomatic infection could be the source of infection. Okay, this is very important. Droplets from coughing, sneezing of an infected person spreading through the air and close contact are the main transmission ways according to the guideline. And the virus has also been found in stool and urine. Thus, stool to mouth could be another way of person-to-person transmission. So this is, I think, this is unique and in the discovery of transmission. As for the susceptibility, at the beginning, people consider it as the disease just spread of the people with old ages, elderly people, or the person with underlying diseases. We call it as medical condition. Those people are susceptible, but in the end, in late stage of the pandemic, and we found it that all ages of population are susceptible, even the young adult, very healthy, and also some infants. Okay, so basically all ages of population are susceptible to this disease, this virus. For the diagnosis of COVID-19, let's look at the pictures here. The left corner one here shows many white dots. We call it as patchy shadows in the lungs. Okay, for this type of infection, it is usually mild. However, when you look at the right panel here, you can see a large area of white lung here. We call it white lung in clinics. So it is called frosted or ground glass-like lungs. This is happen in severe infection, severely ill people. Okay. The symptoms of COVID-19, as I mentioned before, you can see fever, dry cough, fever, feel not well, nasal congestion, running nose, sore throat, muscle pain, and diarrhea sometimes. For the clinically ill patients who develop difficulty in breathing and hypoxia from pneumonia after a week, and then further can develop to respiratory distress syndrome, and then further to multi-organ failure, and then leading to patient death. So there are many cases who died from this infection in China, and I have seen in other countries as well. For the incubation period, it is said about 1 to 14 days, but usually about 3 to 7 days after exposure to the infected person, or let's say the droplet of the secretion from coughing, sneezing, or aerosol. There was report saying an incubation period as long as 21 days, but it's very rare. But again, we need to be aware of this as long as 21 days. Again, continue with the diagnosis of COVID-19. Right now, we are focused on laboratory diagnosis of the disease. There are many useful significant parameters in laboratory diagnosis. I have summarized some most important and significant parameters here to share with you. The first one is the hematology analysis. We know that this technique, this test, is very simple and very simple and easy access technology. So when you perform the hematology analysis on blood sample from a patient, you can see the WBC, which is white blood cell, can be normal or decrease at early stage of infection. However, you would see most of the cases that the lymphocyte is decreased. We call it lymphocytopenia, and also eosinophil is decreased, becoming eosinopenia. And also, a lot of time you can see elevated C-reactive protein level in the blood, and the erythrocyte sedimentation rate increased in most of the cases. And also in some cases with severely ill patients, you can see elevated D dimer as well. And also the T cell subpopulation can be observed with reduction and by flow cytometry. For chemistry, you can see elevated of liver function enzymes, lactase dehydrogenase, creatinine kinase, and myoglobin can be seen in some patients. And again, in severely ill patients, you can see the troponin alteration as well. Okay, and then also the peripheral blood lymphocyte reduction continuously. And you can also see sometimes elevation of other inflammatory cytokines, for example, the interleukin-6. Okay. However, one thing is here, the procalcitonin is usually normal. For the etiology, the nucleotides of the virus from nasal pharyngeal swab or sputum or lower respiratory tract excretion or blood or stool can be detected by real-time RT-PCR technique or by next generation sequencing to confirm the diagnosis. And also, I would like to mention the real-time PCR, which is nucleotides amplification technique. This is the gold standard for diagnosis of the virus infection. Okay. For the serology, the IgM is usually positive after 3 to 5 days of onset, and then the IgG is stronger in recovering period because the IgG developed later than the IgM. So when the patient is in recovering stage, so the IgM become stronger and stronger. Again, I would like to mention the asymptomatic infection, or we say subclinical infection again. Some infected patient, we say person, who does not have clinical manifestations but secretes virus. So this kind of person become infectious source. This type of infection can be diagnosed by laboratory techniques such as the virus nucleotides detections, PCR. And for this kind of person, they may not have any symptom, they may not develop to any disease, and then just carry the virus and becoming healthy carriers, just like the hepatitis B healthy carriers. Okay. However, the capability of COVID-19 transmission or spreading from infected person who is in the incubation period or asymptomatic infection is still unclear and lacking of scientific evidence so far. But we should be aware of this. Yet the risk assessment of this type of hidden source of infection is very important for the final elimination of the pandemic. Now let's review a little bit shortly about the treatment of the disease COVID-19. Since again, I already mentioned previously the disease, the spreading the COVID-19 was is happened in Wuhan in China first in December. So I believe the first report was in December 12, 2019. So and again, there's no any effective antivirus drug available so far, although some of them with optimistic still in clinical trial. So when the doctors treat this kind of disease, the patients, they basically just order and manage the patient as supportive treatment, and the patient just maintain treatment under this method in clinical practice in China. But one thing here in China is very unique. I would like to mention is the Chinese herbal medicine, which is the traditional Chinese medicine, is believed to be effective for COVID-19 treatment, especially for patients with mild infection. So I don't know if there is any Chinese herbal medicine available in other countries, but I know for sure in the United States. Okay, so the clinical outcome of COVID-19 for patients with mild infection usually have a favorable prognosis. However, the outcome of severely ill patients is usually poor. The estimated death rate is about 2%. Reports mentioning about some recovery discharged COVID-19 patients, for example, after 3 times of negative virus nucleotides by PCR, regained positive PCR results in throat swab or stool, even in urine samples. So this is very weird. So causing a debate on the diagnostic criteria and virus capability of spreading right now in China. Okay. This is also an interesting thing. Now, when a doctor see a patient, so he or she has to make a decision, a diagnosis on this patient. So the doctors will collect all information they will have. For example, from hematology analysis, they see here blood samples here, and then he or she may and also collect clinical manifestation of the patient, and also they will look at closely at the CT scanning result. See here. We know that the CT scanning is very obvious and then straightforward and of the evidence. However, although it's fast and easy in access, but it's ambiguous in early stage. You don't know what caused this like patchy lung or whatever, but it's not very typical and not decisive. And again, we mentioned before that the gold standard molecular diagnosis of PCR for the amplification of virus nucleotide. We know, although it's gold standard, but it's costly and it's not easily accessible, and it demands sophisticated work. You have to have a special lab. You have many unique and sophisticated analyzer, PCR machine, etc. is not as convenient as like hematology analysis. Okay, so this is why this is the focus of the talk today about hematology analysis. Let's look at some data here. I think generated in China by Chinese physicians or scientists. See here, for the blood analysis, hematology analysis, the WBC usually normal or decrease and about at the beginning and about 24 to 30% of out of 73 patients cases here were decreased. And for lymphocyte count, there were 63% out of 41 cases patients had decreased lymphocyte count. Okay, and for CRP, 86% out of 73 patients cases had increased CRP level in blood. And again, the eosinophil count is also decreased in the patients not every patient, but you can see and see here the median number of the parameters here, lymphocyte and percentage and lymphocyte count and is eosinophil and CRP here. You can see here. For patients, so the decreased lymphocyte and eosinophil count elevated CRP level in peripheral blood. Those parameters are most often showed up in clinical laboratory. Here's analysis. And the CBC test is the primary method to screen suspected COVID-19 as what we have the experience here in China. So the routine blood test is fast and fully automated analyzing method to avoid hospital infection from aerosol transmission, and its cost is low comparing to other other techniques in laboratory. Why we said it can avoid hospital infection from aerosol, because we know already that when you open the blood tube, blood sample, or even the worse in the secretion, for example, the mucus and the sputum of the patient, so the virus will release, spread out of the tube, the sample, and then get into the air and become aerosol infection, okay, transmission. Now let's look at the CRP analysis in laboratory setting. So and its value in the diagnosis and prognostication of COVID-19. Look at this data. You can see the patient results average, or let's say mean level of the CRP from different groups of observations here. This observation, this study has 73 cases, and the other one is 38 cases, and another one 128 cases, and then another one with 12 cases here. And you see the average of CRP level in the blood. They are all higher than normal ranges here. So this is the CRP is very important in the diagnosis and also the prognostication of COVID-19. So I think you guys already know that CRP is the C-reactive protein, which is an acute phase protein in inflammation and infection. And scientific reports already mentioned that the CRP increased within 4 to 6 hours of inflammation, and the level doubles every 8 hours, peaking at about 36 to 50 hours, which is 100 to 1000% higher than normal value. Okay. So the level and duration of CRP is proportional to the severity of infection. That means the more serious of patient, the higher level of CRP in his or her blood samples. Okay. And now let's look at another parameter which is very important and significant as well in clinical diagnosis and prognosis of the COVID-19 patient. The NLR denotes the neutrophil to lymphocyte count ratio. It is calculated from CBC result, which is a hematology analysis. It is very easy to use, and then our instrument analyzer automatically give out this parameter, the result. So a study in Beijing showed that the cutoff value of NLR is 3.13. So with a sensitivity of 0.875 and a specificity of 0.717. So when a doctor judges a patient who is going to an ICU unit or not, so the doctor, based on the parameter of this patient should be transferred to ICU or not, based on the age. If the patient's age is older than 50 years and his or her NLR is greater than 3.13, so this patient should go to ICU unit. Okay. If in other words, if the NLR is smaller than 3.13 or the age is younger than 50 years, the patient should stay quarantined at home or community hospital. We call it in Wuhan as large cubic-like hospital. Okay, so this is very important and easy to use. And again, you look at this data reported from several groups of studies and mentioning, showing here the NLR ratio here, very important and very unique, useful here, and all greater, higher than 3.13. And here, when we look at the age, combining with NLR and then see the result of the NLR parameter here. So except for the patient number 7 here with 63 years old, and the ratio is still a little bit lower than 3.13. All others are consistent. Okay, and then people have done, I think a doctor physician in China have done the family cluster analysis using the NLR to classify, to identify the spreading, or let's say transmission. Okay, and again, the NLR parameters here to be a new prognostic indicator in judging the COVID-19. So you see here the data showing here from scientific paper showing here the first one here is neutrophil count. You see the yellow line here is going up, means denotes the non-survivors. When you see this kind of curve going up, keep going up, so the patient's consequence, the outcome is poor, mostly died. Okay, And then you see the lower one curve here in blue. It's not going up sharply, just a little bit. And then this kind of patients usually tend to be mild, and the outcome is good, so favorable. Okay, and you look at the middle one here. That's lymphocyte count. And lymphocyte count is opposite to the neutrophil count. It keeps going down when you see the patients in severe condition, so serious condition. So it means bad. So the consequence is bad. So the trend is keep going down sharply. And then here is the NLR. You see the yellow line represents the non-survivors. You see it keep going up and then sharply here, and then comparing to the blue one for the survivors. So this is flat. Again, here when you look at the time course, here again the neutrophil and WBC count, you see here it started going up on day 5, and then the peak is on day 13, which is severe. Here the patient is severe here, and then when it going down here, you can see the recovery of the patient. Okay, and then same thing here, but the trend is opposite for lymphocyte. See here, starting from the beginning, day 1 is still normal, and then keep going down, and up to the day 13 is where at the lowest level, and then that means the patient corresponding the patient severe severity. Okay, and then going up means the patient is recovering. Okay, here is the NLR ratio going up here, and then here this is the CRP going up and down and recovering, so etc. Now we got some good parameters and significant clinical values from routine hematology analysis for the diagnosis and treatment and management of COVID-19. So this routine hematology analysis exerted significant clinical value in COVID-19 diagnosis, and thus it can be used as a routine screening method in clinical practice. Hematology analysis is helpful in guiding COVID-19 treatment, and then hematology analysis plus CRP plus combining NLR ratio have shown us a significant clinical value in COVID-19 outcome evaluation, and therefore the combinatory analysis of these parameters can be used for patients' prognostication as well. I would like to share a story about the fighting against coronavirus and the disease it caused in Wuhan, China. Here, I believe myself, I think it's amazing and also very touching story here. People in China here built a hospital with 1,000 patient beds in just 10 days. I think a lot of media reported this event globally. So you see this picture here. The hospital is named as Shan Hospital. Shan means in English means Fire God Mountain Hospital. Okay, and more than 14,000 doctors and nurses work there in this hospital to save a lot of lives. And as Mindray, we offer many instrument analyzers, including hematology analysis and also chemistry, immunology, and also coagulation, a lot of equipment, medical devices to this hospital. So we are proud of this, what we have done in fighting against this pandemic, this crisis in China. So in here, I list some hematology analyzers which Mindray offer globally. Right now, they are all fine and very excellent instrument analyzers, which can do all the jobs I mentioned previously. Okay, and this is the assembling line of the analyzer of our hematology analysis, and here all kind of different model you can choose from. See here different models, and thank you very much for coming to this seminar.
Okay, so thank you everyone. Thank you, Dr. Huang, for your excellent speech. And next, I would like to invite Dr. Ramon Simon Lopez to give a topic on cytomorphometry in coronavirus. So Dr. Ramon is responsible for scientific research and medical affairs in Mindray. He's an expert in clinical and laboratory hematology, oncology, immunology, coagulation, and so on. Dr. Ramon had over 40 years experience working in both laboratory and hematology industry, and has 8 patents accomplished and over 100 scientific papers published. Now I'm going to invite Dr. Ramon to share his screen and give the presentation. Hi, Dr. Ramon, can you please show us your screen?
Yes, before to share my screen, let me introduce myself. I am passionate for hematology, and in my talk, what we are going to do is to explain the process a little much more in detail, how we obtain all these parameters and solutions that we think can help to the management and to the decision what to do with the patient of coronavirus. And now I am going to share my screen. Yeah, everybody can see now the screen?
Oh yeah, now it's perfect. Please go ahead, Dr. Ramon.
Perfect. Okay, let's begin. Here we see the electronic microscope photo of the coronavirus, COVID-19. Here is a representation how the virus will look like if we can see in 3 dimensions. Here we make a review of the actual statistics of the COVID outbreak. In green, we have the total number of cases per day in the month in the world. In blue, the Chinese. As you can see, till the middle of the graph, the majority of the cases come from China. But after China became a plateau, and it begins the cases out of China that are in red, with now practically all the new cases come from the rest of the world. The important is that here I mentioned that the percentage of severe cases that requires a medical treatment are 19%, and from that about 5%, 4.7% are critical and need intensive care unit and artificial respiration. This is a dramatic slide because it's the number of deaths per day. Here we can see the beginning of the graph, the cases, practically all of them from Wuhan, China. We see a peak in the moment that China reconsidered the diagnosis of some previous cases that were not fitting the whole criteria, but was not real one, because you need to divide this peak with the previous cases. And you can see that it came a plateau, and after it was a decrease of the cases in China. After it begins, continue the number of deaths in the rest of the world, and you can see that now the slope is exponential. In this moment, today is higher, but of course, I made the statistics 2 days ago. The cumulative deaths are 6,900 cases in the whole world. Now are more cases in the rest of the world than in China, and I estimated, calculating the slope, that the cumulative deaths, if the slope continues the same, will be about 81,000 deaths at the end of this month. Here we see an important fact. The percentage of deaths with coronavirus, if the country has a very good healthcare system, enough to treat all the patients, and ideally, as Wuhan did, creating a hospital only for these patients, because the problem we face in Europe is quite difficult to create a hospital in few weeks, or that if you don't isolate the patients and you put the patients in a hospital, that there are bone marrow transplant, oncologic patients, tuberculosis, etc. The normal patients that are in any hospital, the death rate will be much higher. In addition, when the system becomes saturated and intensive care units are full, now in many countries they are beginning to habilitate hotels for to treat these patients. The infection death rate can be 7%, like now in Italy, arriving to 8%. But the reason it's a clear increase when the system is saturated. If all the countries that now are not yet in this position, if somebody hear me that is in the healthcare system of any of the other countries, please build hospitals, because that is serious, and we need to do similar than China did, create hospitals to have enough rooms for the severe and critical cases. Here you can see the comparison with SARS, 72%, and the COVID is 7 times more deadly than the H1N1, that is the worst influenza. Here, it's the number of total patients, in that we can see the influenza, a normal period in 100 days when it begins in winter in any country. This is an example of a country. And here we can see the COVID infection. Here we can see clearly that it's 3 times more effective than the influenza H1N1. And as maybe it's because nobody has antibodies to this virus. Many people have previous antibodies to the H1N1 from previous infections. But this is a fact. We are going to face that is going to be near 3 times more effective than influenza. The estimation now that in America will be about 2 million, between 500, 700 and 2 million deaths when will become as frequent as the influenza H1N1. Now we are going to see the hematology research studies that we did in Mindray. The participants of these studies, you can see here the authors. Sorry. And the first patient was, the first case was a patient that entered in the hospital as a mild clinical case, became severe, and finally recovered satisfactorily. We collected the blood samples of the patient with coronavirus infection from the moment that the patient entered till the moment that was released. We recorded the clinical symptoms every day too. Here we can see that was similar that was shown by Dr. Huang, that here we can see that at the beginning, in the first square left top, these the white blood cells and neutrophils. You can use any of them, but of course better the neutrophils. That shows the peak when the case was really severe. But this probable bacterial infection that was over-infecting the patient together with the virus was causing this neutrophilia, and after decrease, came back again, and finally was recovered. In this case, the treatment was successful. If we can see in the top right, the lymphocyte absolute number. As you can see, is in this viral infection, what is dramatical, somebody asked how we can differentiate this infection from other viral infection. I think it's clear, is the lymphocyte decrease. Normally, you never see this lymphocyte decrease in any of the other viral infections. the reason that this virus is also sensitive in some few experiences we have against using antiretrovirals that are used into the AIDS, looks like this patient, this virus may be infect especially the CD4 cells, and that is the reason. But we don't see this decrease in lymphocyte infections to level of the total lymphs of 300-400 like we see in the coronavirus. In this patient, unfortunately, that was reversed and the lymphocytes came back again to the normal levels, even higher. And in this case, was as a normal viral infection that you have even, in this case, at the end, 2,600 lymphocytes, that is in the higher level of the normal values. For this reason, yes, after recover from this phase of it becomes like another viral infection with an increase of the lymphocytes and with atypical lymphocytes in the bloodstream. In the moment of the decrease of CD4 cells, you can see practically in an AIDS inactivity because it's a severe immunodepressant. The NLR shows the combination of both that are independent because it's not a cytopenia like an aplasia. Lymphocytes goes down, but neutrophil goes up. It's not, it's independent, and this is the reason of the NLR because it's both parameters, lymphocytes and neutrophils, are independent, and we can use it in a formula like NLR, and in this case, I think it's very useful. CRP again at the bottom right shows the peak of the possible overinfection with bacterium, and after recover to normal values. Here we can see for the people that like the plots, you can see in the total CVC, not easy to see all the parameters, but we have checked all the parameters. And here in the right, the more important, the lymphocyte, the RDWSD, the platelets, and the NLR. And you can see how the patient that goes in different levels, before was the platelets were low, the RDWSD was higher, okay? Here the platelets are normal, the RDW is lower, and the lymphocytes become normal. But the reason that is the evolution of this patient with the plots and the numbers. And here the clinical features. You see at the beginning, it begins with like a fever. The chest CT scan was normal. After was a little bleeding, a glass patchy. When it became the difficulty of breathing, the dyspnea, was a significant progress of the previous last behavior of the lungs. After was beginning to use the ventilator, in that was a critical severe status. After it was reducing the breathing difficulties, but high throughput oxygen. In the chest CT scan shows a double lower lag improvement, increasing lesion in the remaining areas. And finally, don't need the oxygenation, and was a slight absorption of the lesions, fibrosis, and finally was recovered. Fibrosis is like, also we can compare these CT scans and X-ray with other interstitial pneumonias, but this is so severe that is practically white. It's incredible how is the fibrosis of the lung. Summary, we found an increase of white blood cells and neutrophils in the severe clinical situation, decrease of lymphocytes in absolute number in the severe clinical situation, increase of CRP, and increase of NLR in the severe clinical situation. The second evaluation was in the same hospital, in the GSA hospital, in that we tried to differentiate severe from non-severe coronavirus infected patients. We were collecting 182 samples from 45 inpatients with coronavirus infection. 36 were mild with good outcome, 5 were moderate severe, and 4 were critical severe and with bad outcome. Here we can see similar results than the previous one case study. The case study we saw before was an increase with these three asterisks showed that the significance is less than 0.001, very significant. The neutrophils were high, the lymphocytes were low, NLR was high, and RDWSD was high. I have to mention that RDWSD is a very good parameter for the coronavirus, but is more in a specific that lymphocyte lymphopenia, low lymphocyte count. This is a reason I recommend to check the previous RDWSD when the patient enters, because there can be other causes for high RDWSD that and it's important in this case use more the delta than the reference values, because we will observe from a previous RDWSD can be high for iron deficiency, can be high for many other reasons that we know. It's quite not rare to find in a university hospital before the coronavirus higher DW. For me, the important is to see the delta check, the difference from the patient entered during the evolution in the hospital. And here the ROC curves, some of them impressive, like NLR with a ROC curve of 0.89, fantastic. Lymphocytes also shows a very good ROC curve in green. NLR is in blue and in the left of the slide. Neutrophils were also good. And the formula NLR here, we begin to create a formula in that we use NLR plus RDWSD using logistic regression, in that we combine in the best way the parameters that we think that can be the best to follow up the coronavirus. Of course, again, here we can measure the NLR every day, and we can see that sometimes it's much more significant to see the evolution of NLR, of this formula, than a single value if we don't have a previous one. For me, it will be more important that the single measurement of this flag is to see the follow-up of this flag that will indicate the severity, if the patient is going better or if the patient is going worse. Okay, the results, again, was very similar. It confirms the first case, lower lymphocytes, higher neutrophils in the severe patients. And the idea is that are overinfected with bacteria sepsis. Their DW is higher, and it is possible to combine both with the parameter NLR, neutrophil to lymphocyte ratio. Here the formula and the cutoff that is patent pending. The cutoff will be more than 1.06. But as I said, for me, will be more important the follow-up of this, of the result of this parameter obtained with logistic regression. Discussion, it is possible maybe to differentiate mild from severe patients with NLR RDWSD formula with a cutoff more than 1.06 with an area under the curve of 0.94. It has asked some of the attendants how we can differentiate that from other viral infections. And I think, of course, we have every patient that enter in the hospital with clinical symptoms now is tested for coronavirus. Can be that has coronavirus and influenza H1N1, yes, for sure, but quite the epidemic and also the test that everybody have. And now with the actual test, we can have the results in 4 hours. I think immediately you can exclude and to see if it's really a coronavirus or not. Of course, with 45 patients are necessary more studies to confirm the fact. And now the last evaluation that will be the more complete. Here I will spend a little more time. This study was done in 92 patients with COVID-19 infection. Were 447 samples from 92 patients. 59 were mild, 16 were moderate severe, and 19 were critical severe and bad outcome. Here we can see more details of the groups. We can stop a little that you can read it. The group 1 was mild and moderate together. The clinical symptoms were mild, and there was no signs of pneumonia on imaging. The moderate with fever, respiratory tract symptoms, dyspnea, and imaging shows pneumonia. The group 2 was severe, meet any of the following. It's like a score: respiratory distress, respiratory rate more than 30 beats per minute. In the resting state means oxygen saturation less than 93%. Arterial blood oxygen partial pressure, oxygen concentration less than 300 millimeters of mercury. 1 millimeter is 0.13. Group 3, critical severe patient group, are patients in intensive care with respiratory failure and shock many times. The group 4, and that was new in this study, we selected for every patient the previous results before they change from mild to severe or from severe to critical severe. The group 4 is when they change to mild, moderate to severe, and the group 5 are the controls of the patients before they become critical severe. We did that trying to see before it occurs, in order we can have preventive measures. If the failure is because bacteria, we can begin treatment of bacteria before it's a sepsis, when it's only a bacteremia. And that is the purpose of that, in that we try to predict, for the reason when the patient is not severe, when it's still in the group of mild and moderate, to predict when they are going to go worse. And the same, when the patient is going to enter in intensive care, if we don't do anything in the group 5 to predict, that is predictive analysis. Here you can see the statistics without the predicting groups. In that, we check here in this statistical analysis, we were open-minded, we were thinking out of the box. We check everything in the CDC and differential, including the research parameters and everything. And here you can see the mean values for every of the groups. The age, of course, are older in the group 3, that is the critical severe. The age is also a very good parameter. The hemoglobin was lower in the group 3, but also lower in the group 2. The micrograms, surprisingly, are not very, in absolute number, are not very high, and but are significant. For the even small values, as you can see in the comparison, group 1, that is the mild, moderate to severe, and group 1 versus 3 is very significant, even if the values change a little. The lymphocyte absolute numbers, here you see the percentage of decrease or increase are also important. The WSD, the monocytes are also important. Decrease in the group 3, and I think that is becoming coming together with what is called immunoparalysis, that is the decrease of the positivity of the neutrophils in absolute number, you can see, is absolutely correlating. Group 2 is 9,000, group 1 is 6,000, and group 3, near 13,000. Is a very good parameter and correlates very well with the critical status of the patient. NLR, the same, okay. LCR is also good. PLR, platelets are very important. When they decrease, you are really in a critical situation, and leukocytes too. And here, the same that previously, but you can see the group 4 and 5 that are the previous results before something bad happens. And you can see here the comparison of the group 2 and group 4 that are patients that become 4 and comparing with the first result before they become 4. And you can see here which parameters become significant, like hematograms, lymphocytes, neutrophils, NLR, PLR, and leukocytes. And the same for groups 3 to 5. Okay, here it appears the lymphocyte Z that it's increasing in the group 5, that is previous to entering the severe. The lymphocyte size, somebody asked in the chat about the morphology of the lymphocytes. Lymphocytes become activated and reactive before become severe, with a lymphocyte Z of 834 before the patient enters in the severe status. The same with monocyte Z, the size of the monocytes. Before to enter in a severe status, the monocyte size measured with this subpopulation data increase a lot. And the same, the neutrophil size. Looks like everything is activated. It's a big activation of the neutrophils, monocytes, lymphocytes before you become severe. In some of the cases, I have seen eosinophilia, also previous to entering the severe status, that can show this like reaction, big reaction before this happens, like it's a storm of cytokines, that predict that the patient is going to enter in a very bad situation. Here, maybe it's very good to show the same with the whisker plot analysis. in that you can see the lymphocyte absolute number in all the groups. The group 1, remember, is mild moderate. Group 2 is severe. Group 3 is critical severe. And the group 4 is patients that before to enter in severe, and 5 patients before to enter in critical severe. As you can see, that is clearly that the lymphocytes with a very significant P, it's decreasing when the patients become moderate or severe. The same for the neutrophil absolute number, very significant increase of neutrophils, but very proportional. That shows that the degree of the severity can be measured when we are overloaded with a lot of patients and few doctors. The degree of the severity can be measured maybe with the neutrophil count. The RDWSD, again, very significant with the patient in group 3, and is so clear. And that is important for a follow-up. As I told you, even if the patient have a previous higher RDWSD, will increase higher. And to follow up this parameter together with neutrophils can be very good to see the severity, how the patient is going better or worse. Platelets, somebody mentioned the platelets. Are we going to talk about platelets? For sure. Platelets here is clear, are not changed in the severe, that are not critical, that don't need, and decrease clearly when the patient become in this, after this storm of cytokines. The platelets, maybe the D-dimer will be positive too, and we have to analyze if the patients also have intravascular coagulation. The thing is, yes, platelets are a good indication of severity with a very significant P. And here, the cell population data. My talk is more about cytomorphometry. I was the first article published in the world about cell population data. How we can use the size, not only the red cells and platelets, also the leukocytes. I published myself, was in malaria. And here you can see that the monocyte set, the size of the monocytes, is a very good prediction factor about that the patient is going to enter next day or next days in the critical severe. That is maybe correlating with the IL-6, with the storm of cytokines, and maybe the decrease of the positivity for HLA-DR in the monocytes that the patient began with immunoparalysis. You can see clear the whisker plot analysis is absolutely not overlapping and can be a very good parameter to investigate in the future as a prediction of critical severe clinical situation. The NLR, the neutrophil lymphocyte ratio, we can see here the different situations, okay? And with very significant P in the group 2 and 3 is a very good parameter. Of course, together with the coronavirus endemic pandemia, the number of cases, we have to use that, and the tests that every day are becoming faster, and we will be able to do, I am sure, in a few hours. Results, finally, the same, that's similar, no news, only the monocyte zeta increase, the size. That is important to mention that the morphology of the cells can be automated today with Mindray instruments. And here the cutoffs. In the severe cases, the lymphocytes are lower than 630, and the absolute neutrophils are higher, more than 9,200 in the patient with bad outcome, and the platelet decrease, the cutoff is 184. The RDW increase is 41.6, but as I said, we need to consider the delta check and the previous results of the patients when, if we have any previous delta check of the patient before, because it came for another reason to the hospital, or the results from the first day in that the patients entered in the hospital. Here, the possible causes of the decrease of the absolute lymphocytes. I think the virus can be selective to CD4 cells, but also there is a very important research today about the MDSC cells, myeloid-derived suppressor cells. These cells are the enemy of the immune system and are increasing cancer and increasing viral infections, and these cells provoke immunosuppression. How we can detect that? Because the monocytes become negative for HLA-DR, sometimes also negative for the CD14. The monocytes have to be measured with the CD33 that is in the monocytic area that are positive, and they are DR negative. More than 30–40% of the monocytes are DR negative, and is well described in sepsis and in cancer that the patient have immunoparalysis. I think we need to investigate that because there is some treatment, maybe not proved yet, but cimetidine, a very old anti-acid drug, is useful for MDS to cure or to treat this situation. The absolute neutrophils increase, I think, if we don't have time or there is no any culture or gram stain that permits to see which bacteria, we need to cover when the neutrophils increase the patients with an antibiotic that covers the more frequent germs in the area. The platelet decrease because sepsis, and their DW increase because oxidative stress inhibit red cell maturation factors, lack of nutrients, inflammation. The cell population data, the monocyte Z decrease in the severe cases, increase before that happens. Remember, it's the group 5. The patients that become severe 1 day or 2 days before have an increase of the monocyte Z, but after it decreases, and that is also important, the follow-up of this parameter. And the neutrophil fluorescence, even if there are not many hematograms, the neutrophils are activated and increase in the cases with bad outcome, more than 483, and stay normal in the severe cases, only 8% of increase. The result, the summary is BC 6,900. Results may help in the classification of severity in patients affected with COVID-19. Infection can be predict before occurs. Maybe we have to double check for sure all these results. And thank you for your attention. This is a lymphocyte from a young lady, 17 years old, with a mononucleosis infection, Epstein-Barr virus. I did myself the photo, and it was real, no Photoshop, with the form of a heart. Thank you so much.
Okay, thank you so much, Dr. Raymond. Does anyone have any questions? Please raise up your hands so that we can unmute your voice call.